Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Today we are going to be talking about bronchiectasis. Bronchiectasis is progressive, irreversible dilation of cartilage-containing bronchi. Three etiologies of bronchiectasis have been described, with a final common pathway of mucus plugging, superimposed bacterial colonization, and inflammatory response. Bronchial wall injury, typically from infection or inflammation, bronchial lumen obstruction, and traction from adjacent fibrosis have been noted to be the main etiologies of bronchiectasis. The morphologic classification of bronchiectasis is most useful as a rough gauge of severity. The first one is cylindrical bronchiectasis. That's the least severe. And in this case, you have just mild bronchial dilation, more like a cylindrical pattern. Then you have varicose bronchiectasis, which is moderately severe, where the bronchi become beaded and irregular. And then cystic bronchiectasis, which is the most severe, where the bronchi are markedly enlarged and ballooned like cysts. So with this schematic diagram, we see the normal bronchi, and then when it's just cylindrically dilated, mildly dilated, looking like a cylinder, it's the cylindrical form. Then it starts appearing beaded in the varicose form, and then in the most severe form, it's cystic. Radiographic findings depend on the severity. In mild cases, that's in the cylindrical type, you would only have tram tracks being visible. It may even appear normal on chest radiography, but if you would see anything, you would see tram tracks, which represents thickened bronchial walls, and these would cause parallel radiopaque lines resembling tram tracks. In more severe cases, there may be extensive cystic change within the lung. So in this image, we see these thick walls of a dilated bronchus here, representing the tram track sign in a case of cylindrical bronchiectasis. The CT findings include the signet ring sign, which describes a dilated bronchus adjacent to a normal pulmonary artery branch. Normally, each bronchus should be approximately the same size as the adjacent pulmonary artery branch. Other CT findings of bronchiectasis include lack of bronchial tapering. Normally the bronchi should taper as it approaches the periphery, but in bronchiectasis, it stays dilated even to the periphery. And mucus-filled bronchi can also be seen in bronchiectasis. Often, adjacent tree and bud nodules are present, likely representing associated small airway infection. So in this image, this is a selected image of a post-infectious bronchiectasis case, and we see the signet ring sign. If we look closely, let's pick this bronchus. You can see this dilated bronchus with the pulmonary artery branch just adjacent. It's making it appear like a signet ring. There's another one just beside it here. So this is a signet ring sign in bronchiectasis. Also, we can see in the periphery where we shouldn't really clearly see dilated bronchi. We can see some bronchi in the periphery are still dilated, representing a lack of tapering. For the patterns of primary bronchiectasis, it may be divided into upper lung causes, mid lung causes, and lower lung causes, or it may be divided into central causes and mid-order bronchi causes. So with the upper lung causes, cystic fibrosis and allergic bronchopulmonary aspergillosis are a major cause of upper lung bronchiectasis. Mid-lung bronchiectasis is usually due to atypical mycobacteria. Lower lung bronchiectasis would usually be due to chronic aspiration, post-infectious causes, immotile cilia, where the cilia are unable to beat mucus out effectively, and immunodeficiency. With the central causes, a major one is Munier-Kuhn disease, which is tracheobronchomegaly. Now let's look at some examples and how they look. So we mentioned chronic aspiration as one of the causes. It's actually the most common cause of bronchiectasis. And in these images, we see a case of bronchiectasis from chronic aspiration. The axial and the coronal CT show bronchial wall thickening. You can see the walls of the bronchi are actually thickened in the bilateral lower lobes due to dependent aspiration. Now, chronic aspiration causes bronchiectasis by causing repeated inflammation and bronchial wall damage, and that leads to the permanent dilation of the bronchi. Then bronchocentric infections such as tuberculosis and atypical mycobacteria are also causes of bronchiectasis. And in this case, we actually see bronchiectasis of the right middle lobe and the lingula here due to Mycobacterium avium intracellulare. We can actually see that this type of bronchiectasis appears beaded, means it's the intermediate form of bronchiectasis, means it's been going on for quite a while. Then ineffective clearing of secretions, like we have in cystic fibrosis, like we have in Cartagena syndrome, also cause bronchiectasis. So in these images, we actually have bronchiectasis from cystic fibrosis with superimposed pneumonia. The radiograph shows upper lobe bronchiectasis. We can see all these bronchiectatic areas, these hyperlucent areas within this upper and mid zone here. We can see some here as well. And then there's also this area of opacity in the apex of the left lung. The CT confirms bronchiectasis here. This appears round because it's an axial, so we are cutting the branches of the bronchi in transverse. A coronal would show them more tubular. And we also see this area of consolidation in the left upper lobe, which represents a pneumonia. Now, congenital connective tissue disorders like Mounier-Kuhn, which is a connective tissue disorder causing tracheobronchomegaly, leads to recurrent pneumonia. There's also Williams-Campbell, which is a rare disorder of the 4th to 6th mid-order bronchial cartilage, which may be congenital or acquired as a sequelae of viral infection. And in this image, we see tracheal dilation. The calipers that are here show it's up to 3 centimeters in diameter. And we also see severe cystic bronchiectasis. This is very severe bronchiectatic change in a case of Mounier-Kuhn disease. Now for a bonus, we'll talk about bronchiolithiasis. Bronchiolithiasis is a rare disorder of calcified or ossified material within the bronchial lumen. And this is caused by erosion of an adjacent calcified granulomatous lymph node from some prior granulomatous infection, like tuberculosis, for instance. Bronchiolithiasis clinically presents with non-productive cough, hemoptysis, and air trapping. So in this image of a patient with a history of treated TB, we can see some calcified lesions. This is just one slice, but there are multiple calcified lesions within the lung, especially in the right. And these calcified lesions were old tuberculous bronchioliths within the bronchi. You can, if you are to follow this bronchus, you can see that this specific one is right in the path of the bronchus. This was a bronchiolith in a case of treated TB. Thank you very much for your attention. I hope you found value from this presentation. If you did, give it a like, comment, ask a question in the comments. I'll try to answer. Share to someone who might need this. And I'll see you in the next one.